Thank you everybody for joining us this afternoon from wherever you are in the country. And welcome to our webinar, What's the Hoopla About HIPAA? HIPAA 101 for Advocates. And I am joined today with staff from CHLP, which is the Center for HIV Law and Policy, NASTAD, and the Center for Health Law and Policy Innovation at Harvard. A little bit background about CHLP. CHLP is an abolitionist legal and policy organization that envisions and works for a world where HIV and other stigmatized health conditions are no longer criminalized, but met with compassion and resources to thrive. Here are our panelists for today. I'll let y'all introduce yourselves, and we'll start with Kay.
Hey everyone, I'm Kay. My pronouns are he, him. I'm a staff attorney at the Center for HIV Law and Policy and based out of Philadelphia. Thanks everyone for coming to listen to what we have to say. And I'll pass the mic to Dori.
Hi everyone, this is Dori Molozanov from NASTAD. Thanks so much for having me here. She, her pronouns. I'm really passionate about data privacy, HIV data privacy, and public health departments. Of course, at NASTAD, we represent state public health departments, HIV programs. So I'm really looking forward to talking more with you all about how public health intersects with some of these really important data privacy considerations that are on everyone's minds. So thanks for having me.
And then, hi everyone, Rachel Landauer. I'm an instructor over at the Center for Health Law and Policy Innovation of Harvard Law School. That is a mouthful, so we go by CHLP. Just add an I to CHLP. And yeah, we're just really happy to be here to chat with you all today about kind of how to think about and approach both the strengths and some of the vulnerabilities of data health information privacy under HIPAA.
Thanks, everyone. So a little bit of housekeeping. Feel free to keep introducing yourselves in the chat and talk amongst yourselves and have any reactions to what's being said. However, we do have a Q&A feature because this is a webinar. And so we ask you to please put any questions that you have that come up into the Q&A. And then we have time reserved at the end of the presentation to answer those questions. And if you can, if there's like a certain questions directed at a certain presenter, please clarify that in the question as well. All right, and then we're gonna go to the run of show. So first we're gonna start off with an overview of what HIPAA is. Then we're gonna go to navigating rights under the HIPAA privacy rule. Next will be a spotlight on data privacy and public health. Next will be legal process and access to health information in court, which I'm sure many of you are interested in your work. And then lastly, we're going to talk about current advocacy to strengthen HIPAA privacy protections. Forward, and let's get started.
Hey, hi everyone. Before I get started, I just wanted to talk a little bit about myself and about NASTAD. I mentioned that NASTAD is a membership organization. We represent state HIV, state health department HIV program, HIV, hepatitis, and drug user health programmatic activities and staff. Our mission is to advance the health and dignity of people living with and impacted by HIV, AIDS, viral hepatitis, and intersecting epidemics by strengthening governmental public health and leveraging community partnerships. And within that, we believe that health departments can and must balance confidentiality and trust in governmental public health with the need to use data for effective and innovative interventions. And a significant part of my work at NASTAD is helping state health departments accomplish that. So that's a little bit about kind of me and why NASTAD has joined us here today for this important conversation. So for our goal for today is to demystify some of the web of laws and policies that affect privacy of HIV-related healthcare data and also HIV-related public health data, and to talk about what those laws and policies mean for your work and for your clients. So we'll start with an overview of HIPAA, its history and purpose, its key components, some basic rules that can help you assess whether HIPAA is applicable to a given situation. There is a lot to say about HIPAA. We're really just doing a crash course today. We might not answer every question that you have about it. There will be Q&A later, and of course we're available, or at least I'm available as a resource after the webinar is over. But I also wanted to share a few links in the chat now that I personally find to be extremely helpful. I think, in my opinion, HHS, the U.S. Department of Health and Human Services, has done a really good job of developing comprehensive but accessible HIPAA information for the public. So I do recommend bookmarking these if HIPAA is coming up in your work. So with that, let's dive in. First, history. Some key goals of the HIPAA legislation were to improve access to health coverage and to make healthcare delivery more efficient. So, for example, HIPAA created important consumer protections for employer coverage. It also created a standardized classification system for medical diagnoses and procedures, which you might know as ICD-10 codes. Electronic healthcare transactions were expanding rapidly in the 90s when HIPAA was passed, which certainly helps with the law's goal of making healthcare delivery more efficient, but it also carried new risks that sensitive health-related information would be exposed to hackers or to other entities that are not supposed to have it. So, to that end, HIPAA also required development of nationwide standards for privacy and security of electronic healthcare information. Next slide, please. And thus we have the privacy rule and the security rule, which are two key components of HIPAA. These rules govern how certain healthcare entities, called covered entities, protect and secure certain kinds of information called protected health information. We're not going to talk much about the security rules today, so I'll just give a little bit of background on it. This part of HIPAA sets standards for how information is stored, managed, protected, and shared. It applies to electronic information only, which in 2024, yeah, right there, which in 2024 includes almost everything is electronic. So the security rule might address things ranging from physical storage of data servers to security training for staff. It kind of covers that, it's that how the information is stored, protected, and managed. In our healthcare system, electronic health information is stored and shared in a lot of ways. And it makes getting care more efficient and convenient. We get lab results online. Doctors submit claims to our insurance. We get text reminders about appointments. We pay our copays online and our premiums. Our providers can send prescriptions to the pharmacy. The pharmacy can text us when the medication is ready, and et cetera. So all of this is allowed under HIPAA as long as those entities have policies and procedures to keep the information safe and secure, consistent with federal law. And consistent with the security rule, sorry. But for most people, when they think of HIPAA, they're usually thinking about the privacy rule. Who can access their information? In other words, how can their information be used and disclosed? So the privacy rule is what we'll focus on today. When I say use of information, I mean how an entity shares, analyzes, or uses information internally, and disclosure refers to communicating information externally. Again, HIPAA does not apply to every situation involving any kind of healthcare information. It applies only to certain entities called covered entities and only to certain types of data, protected health information. So what do these terms mean? Next slide. Oh yeah, perfect. Covered entity. A covered entity is either a healthcare provider, a health plan, or a healthcare clearinghouse. A provider, like a doctor, nurse, or hospital, is subject to HIPAA if they transmit health information electronically in connection with certain transactions. For example, if they do electronic billing. So I think it's safe to assume at this point that pretty much any provider you see is overwhelmingly likely going to be subject to HIPAA. As an example, many Ryan White grantees are covered entities because they provide healthcare services and they also submit electronic insurance claims. Some entities not covered by HIPAA, this is not an exhaustive list, but some examples that come up are employers, schools, state agencies like Child Protective Services that aren't providing health coverage, or health services, and law enforcement agencies. These are some examples of non-HIPAA covered entities, non-covered entities. Health plans includes health insurance companies, HMOs, most group or employer health plans, and government insurance programs like Medicaid, Medicare, veteran coverage programs. Programs like Ryan White that provide grants or direct funding for provision of care are not considered health plans. But again, many Ryan White grantees could still be covered by HIPAA as providers. And healthcare clearinghouses are entities that process electronic information, such as a billing company. Next slide, please. Public health departments often perform the functions of a covered entity. For example, health departments often operate hospitals or labs. They also administer age drug assistance programs or ADAPs. Health departments do have to comply with HIPAA when conducting these kinds of activities, but traditional public health activities like disease surveillance do not fall within HIPAA. So public health departments are often hybrid entities, which allows them to carve out traditional public health activities from their HIPAA obligations. And then their traditional public health activities would not be subject to HIPAA, which is not to say that those activities have no privacy protections. They do. They're just protected by different laws, which we'll talk about later. Next slide, please. So HIPAA also only applies to certain types of data, protected health information, or PHI. PHI is individually identifiable health information that relates to someone's health condition, the healthcare services they receive, or payment for their care. Identifiable data is data that either identifies someone or that reasonably could be used to identify someone. It is definitely possible for a data set to be missing some components or even all identifiable components, but still be considered identifiable if it's something that kind of reasonably could still be used to figure out who is being referred to in the information. Truly de-identified information does not fall under HIPAA protections, meaning that HIPAA does not restrict its use and disclosure. And HIPAA has standards for determining whether information is considered to be de-identified. But if it is identifiable, it is subject to HIPAA. PHI can include information in a medical record, demographic data, conversations between providers about care and treatment, health insurance claims, billing information, and much more. The privacy rule is not limited to electronic information. It also applies to paper and oral information as well. Next slide, please. I know Rachel will talk more about authorization when we discuss permissible use and disclosure of data under HIPAA, but I just wanted to flag here the difference between a HIPAA authorization and consent. A HIPAA authorization is detailed, specific, written, and signed permission for a HIPAA-covered entity to use or disclose PHI, a person's PHI, for a specific purpose and duration. Consent usually refers to permission given in situations where HIPAA doesn't actually apply at all. There are situations where you might give written or oral consent in a healthcare context outside of HIPAA requirements. So informed consent to receive care, for example, or consent for your provider to share information with your insurance company. There are medical standards of practice. There are state laws that require consent in certain situations. And sometimes providers voluntarily choose to obtain consent. But what's important to know is that if it's a situation where HIPAA requires an authorization, these kinds of consent do not replace that unless they meet the very high standard of detail that is required for a HIPAA authorization, which generally it would not. Next slide, please. And finally, the last vocab word before we move on to patient rights under HIPAA. You'll hear us, and particularly me, talk today about disclosure to public health authorities, or PHAs, under HIPAA. So I wanted to define this term. A public health authority is a government agency, federal, state, territorial, local, tribal, that is responsible for public health matters as part of its official mandate. Examples of federal public health authorities include some of the ones listed here: the CDC, FDA, OSHA. Then there are state or territorial public health departments with jurisdiction over a state or territory. There are tribal governments that perform public health functions. And in many, but not all places in the US, there might also be a city or county health department. And now I'll hand it over to Rachel to discuss patient rights under HIPAA.
Thanks, Dori. Kytara, you can actually head to the next slide. So I think what Dori just talked us through is really helpful for me, in part, to be able to identify more readily, am I even working within the world of HIPAA, right? Is HIPAA governing or creating rights or responsibilities based on who I have in front of me in my scenario, based on whether or not I have a covered entity, whether or not I have protected health information? I'm going to switch gears a little bit now to really move us into a deeper dive on what Dori referred to as the privacy rule, right? This rule, this part of HIPAA that really governs how a covered entity can use and disclose protected health information. And under HIPAA, individuals have several rights pertaining to their own information. We have the right to a notice of privacy practices, meaning an understanding of how information in our record may be used and shared. So maybe you've gone to a new doctor's office, you've been presented with their notice of privacy practices. The source of that is really in HIPAA. Individuals also have the right to access and copy their own health record, right? Providing individuals with easy access to their own health information empowers them to be more in control of decisions regarding their health and well-being. We have the right to request an amendment of a health record. This is really about the right to correct PHI, right? We're partners in ensuring that our information is correct. Although notice it's the right to request and not necessarily the right to an amendment. We also have the right to request confidential alternate modes of communication. So this can be a really important safety feature for folks, right? The right to request that our providers communicate with us at a different location or in one mode versus another. And we have the right to request a restriction. This is this idea that we might be able to request if we want our PHI not to be shared under certain circumstances or with certain other parties, the right to give permission for our PHI to be shared for certain purposes. And we'll talk more about this in a minute. But again, it's that right to request, not necessarily the right to receive. And then we have this right to accounting of disclosures. This is this idea that we're entitled to a report on when and why our protected health information may have been shared for certain purposes. We'll also talk more about this. And then it's not up here, but individuals also have a right to complain, right? To file a complaint with a provider or a health insurer or with the HHS Office for Civil Rights if they believe their rights are being denied or that their health information isn't being appropriately protected. And I think when we step back, these rights are all really important in that they help individuals maintain control over their health information. But they also, when you take a look, they kind of hint at the fact that health information under HIPAA can be shared with different parties in different ways, right? Outside of the patient, provider, or insurer relationship, or who we think of normally involved in our care. And why else might we need something like an accounting of disclosures if that weren't the case, or the right to request a restriction? And so a major purpose of the HIPAA privacy rule is to really define and limit the circumstances in which PHI can be used or shared by covered entities. And so let's talk more about what those rules are. Next slide, please. Thank you. So the general rule, when I think about it, is that a covered entity may only use or disclose PHI when, one, authorized in writing by the person identified in that information. And as Dori shared with us, an authorization is a very specific thing. It's more than just informed consent. You have to cross your T's and dot your I's. It has to be a valid HIPAA authorization. though, in the alternative, the use or disclosure is otherwise permitted or required by the privacy rule. And so while we read about kind of growing numbers of cybersecurity and ransomware attacks on hospitals, we read maybe about breaches of a patient's privacy because someone posted something on social media that they shouldn't have. There's also this prong of the privacy rule itself that really creates a lot of the vulnerabilities that come to mind for us when we think about how patient information might be used or disclosed in more harmful ways. Next slide, please. So what are these other permitted uses and disclosures for which you don't need authorization? The basic concept is really kind of these disclosures for treatment, payment, and operations. That's this idea that my specialist is able to share the results of my recent test results with my primary care provider, and I don't have to authorize that. They can just make that exchange. Similarly, my specialist is able to share that I received a test with my health insurance company so that they can be reimbursed for that service. And again, I don't have to be part of that process. I don't have to give my authorization. That's an exchange that's a permitted use and disclosure otherwise. A really interesting question here is what about social service organizations and whether or not a covered entity can just share information with a social services organization that's not a covered entity as treatment. In those links that Dori shared, there are some really interesting examples around housing service providers, but we don't have a lot of guidance. And so that's one of the areas in which there's sort of a bit of a question mark in how we handle that under the law. But the rationale here, right, is that we're trying to balance patient rights with creating unnecessary barriers to the delivery of our healthcare. It goes back to the idea that HIPAA was built upon this idea of really facilitating exchange of information and efficient sort of delivery of care and payment. Next slide, please. There's also a whole category of permitted uses and disclosures. So a category of exceptions from the patient authorization requirement that we refer to as public interest and benefit activities. There are more than I have listed up here, but I wanted to raise these up because I think they're especially relevant when we're working through potential vulnerabilities in sort of the HIV advocacy space and to our conversation today. So we have disclosures required by law. Some states have, for example, laws about reporting suspected abuse, laws about partner notification for different communicable diseases. A disclosure that is required by a state law is a permitted disclosure under HIPAA. We also have disclosures to law enforcement or for judicial or administrative proceedings with appropriate process built in. And HIPAA specifies what that looks like. But the idea here is that subject to process, you know, we're able to disclose information without authorization to those kinds of bodies there. An example is a prosecutor may use a subpoena to compel production of a medical record relevant to a criminal investigation. And we'll be talking more about this pathway of information disclosure later on. Another one I really want to lift up is the disclosure for health oversight activities, because some of you may have seen this example in the news recently, and I think it's really worth paying attention to. So last year, a Tennessee medical center gave records of patients receiving gender-affirming care at their gender-affirming care clinic to the Attorney General. That was not with the authorization of the patient, but it fit into this disclosure for health oversight activities, arguably. That's what the health is claiming, because it was part of an investigation regarding potential billing fraud. So the Attorney General was asking for those records under this understanding. And then we also have disclosures, that last one there, for public health activities, which Dori will talk a lot more about. But an example that we're probably all very familiar with coming off of the past few years would be sort of the ability to give over reports of, COVID-19 monitoring and surveillance for the purpose of, preventing or controlling the spread. Next slide, please. So regardless, I think, of whether or not we feel like there are valid reasons to share information without authorization, and whether or not we feel that some of those that we just talked about are more valid than others, I think it's really important to note that even in the ways in which our exceptions are designed, they can create challenges to protecting individuals and their health information, especially sensitive health information. So the first is this idea of you have the permission to disclose versus the requirement to disclose protected health information, and like, what's the difference, right? So next slide. So HIPAA tries to set out this distinction for us. We have a permitted disclosure, which is the idea that a covered entity is permitted but not required to disclose PHI without an authorization. And we have required disclosures, which actually a covered entity is only required to disclose PHI, at least under HIPAA, in two narrow instances. The first is to the individual themselves that has the right to their information. And the second is to the Department of Health and Human Services as part of sort of a HIPAA-related investigation. Those are the only two HIPAA-required disclosures. But this distinction doesn't always make its way into practice, right? If we're asked to do something, we might not always question whether we have to, whether we're only allowed to, what's the difference between those outcomes. And then also, this is just at the HIPAA level. And there's other laws like state laws that add layers of permitted or required disclosures, which just further complicates all of our analysis when we're trying to figure out how to proceed. Next slide, please. Some other challenges I see a lot of is this question of whether a covered entity knows how to or has the resources to, or otherwise even cares about pushing back on a request for information. And so we can think about law enforcement asking for a whole slew of information in a medical record. And is the covered entity positioned to really push back on that and say, at the most, you only need X? A related kind of challenge is this idea that once a disclosure is permitted, how much is shared? For most uses and disclosures, they're subject to something called the minimum necessary standard. And this means that a covered entity is required to reasonably limit what's shared with what's necessary to accomplish the purpose of the disclosure. But again, that gets messy pretty quickly. It's an arguably vague standard. And for a lot of kind of those public interest activities, a covered entity is allowed to reasonably rely on a determination by, for example, the public health authority that's requesting it. And so you can see that we might have a lot more information communicated over than is necessary or than might be in the best interest of the individual. And then I think there's this challenge of a risk of redisclosure, right? And so this could be intentional if the party that receives information isn't bound by HIPAA, or, unintentional. If the party isn't bound by HIPAA or other privacy safeguards, maybe they're not planning to secure the information in the same way, and it's more vulnerable to, for instance, a hack. And then it can also be intentional, right? Once I have information, am I able to do whatever I want with it and use it in ways that maybe weren't conceived of by that initial allowance of this. Next slide, please. Permitted uses and disclosures, we mentioned this already, but it's really important to remember that HIPAA is really kind of like a floor for health information privacy. It's not a ceiling. State laws can be more protective. And also, state laws can help redefine and reshape a lot of what HIPAA calls kind of a permitted use and disclosure because of that deference to what's required by state law. Next slide, please. I'm about to pass things back off to Dori again, but I just wanted to come back to this idea of accounting of disclosures, because I think that it can be really helpful. It's a helpful tool in identifying how a person's information may have been shared within a period of time. And that really helps us anticipate potential vulnerabilities of ways in which that information may be. So individuals have the right to request a listing of certain disclosures. It has to include various key pieces of information, like when was the disclosure made within a period of time, what was the disclosure made for, like what was the purpose of the disclosure, and sort of who the disclosure was made to, or the kind of body that the disclosure was made to. And this counts for a 6-year look back period. And so if you're thinking about, how has my information been shared? How has my information been teed up with others? The accounting of disclosures can be one tool to sort of try to hunt that down. On to you, Dori.
Great, thank you. Scroll through my notes here. Okay. So now I want to switch gears a little bit and focus on the intersection of HIPAA and public health. Next slide, please. So since health information has a lot of important uses outside of the healthcare context, HIPAA permits disclosure for certain public interest and benefit activities. This is one of the permitted disclosures that Rachel just explained. So each public interest purpose under this kind of umbrella has specific conditions and limitations to balance the individual privacy interest against whatever public interest may be served by disclosing or using the data. There are 2 public interest and benefit activities that allow HIPAA-covered entities to share certain HIV data with public health authorities. Those are 1, disclosures required by law, and 2, disclosures for public health purposes. Next slide, please. As Rachel explained, there are many situations where HIPAA permits but does not require use or disclosure of PHI. However, there may be state law that requires a use or disclosure, even though HIPAA does not require it. So that state law would generally prevail, and HIPAA would allow that disclosure. Another type of permitted disclosure is for public health purposes. A lot of disclosures made for public health purposes are already required by law anyway, but there could be emergency situations not specifically addressed in state law where public health officials need PHI to deal with the emergency effectively. So in this case, a covered entity may, but is not required to, disclose the information to the public health authority. And it might want to do that in the interest of helping with whatever emergency situation is going on, for example. Next slide, please. So I want to walk through a quick example of how the required by law permitted disclosure relates to public health. And then I'll talk about other state laws that are related to public health data privacy. So the question, under HIPAA, may a healthcare provider report a new case of HIV, which includes PHI, to the state health department without the patient's permission? And the answer is yes, because every state has a law that requires providers to report new cases of HIV to a state or local health department. HIPAA therefore allows this provider to disclose to the health department as required by law without the patient's written signed authorization. Now, in theory, the state law could require written or oral permission from the patient before the provider reports the data to the health department, but HIPAA does not require this. I'm not aware of any states that do. There are few, if any. But theoretically, a state could pass a law that is more protective in this way, or that more protective than HIPAA in this way, or more protective in another way. And one thing to note here is that if a patient requests an accounting of disclosures, which Rachel talked about earlier, disclosures to a PHA would be included in that. Next slide, please. Now let's go beyond HIPAA and talk about what happens to data once a health department has it. Next slide, please. Oh, this looks so much nicer than the one I made. Sorry, I haven't seen this flowchart before. It just looks great formatted this way. Sorry, I had a moment of processing it. Okay, so we're going to follow this flowchart to kind of understand how HIPAA and state public health laws intersect. So actually, on the first question, we kind of already end up hitting a dead end because health departments are not covered entities. The first question is the entity a HIPAA covered entity? I guess it is sometimes it can be a hybrid entity. I should have been a little more clear. For the purposes here, we're going to talk about its traditional public health activities of a health department. So for the purposes of this discussion, they are not HIPAA. They're not subject to HIPAA requirements in the activities that we're going to talk about. So is the entity a HIPAA covered entity? No. So that means that HIPAA doesn't apply, but a state privacy and confidentiality law might apply. But before we move on, let's just walk through the rest of this. If the entity is a covered entity, then the next question is the information public health information? If it's not, HIPAA doesn't apply. If it does, then you'll next want to determine whether the situation is one of the exceptions that under HIPAA that doesn't require a written authorization from the patient. And then from there, proceed following HIPAA or any other applicable laws or policies for use of or disclosure of the PHI. Next slide, please. But again, HIPAA does not generally apply to public health data that's collected in connection with traditional public health activities. So what law does? Let's walk through this diagram now. Over on the left, providers and labs are HIPAA-covered entities. So PHI in their possession is subject to HIPAA. This includes, for example, various types of HIV test results that public health departments then collect. These entities, they share PHI with the state health department or the local health department as required by state law. It's required by law, so therefore it's allowed under HIPAA. But once it gets to the state health department, HIPAA no longer applies because collecting these reports and conducting disease surveillance with that information are not HIPAA-covered activities. So further disclosure after that point is governed by other laws, typically state laws, but there could federal or local laws could also apply. That it's governed by other laws, usually state laws, that authorize the health department to collect or use information to aid in its public health mission. Next slide, please. So how can health departments protect HIV surveillance data? Over time, the purpose and use of HIV surveillance data has changed, with uses expanding beyond monitoring the epidemic to implementing prevention interventions and responding to outbreaks. At NASTAD, our goal is to support health departments, our members, in these important activities, while also ensuring the strongest possible protections to prevent misuse of data, and especially in a context where it's being misused to criminalize people with HIV. So there are multiple tools available to health departments that enable them to protect surveillance data. Of course, the first important protection is state privacy laws. These are generally structured as blanket protections, like blanket confidentiality protections with specific exceptions. So they'll say HIV data is confidential, except can be disclosed in these situations. All states have some laws addressing confidentiality of public health HIV data with varying levels of protection. On this slide, I have an example of a law from Maryland that I consider to be pretty protective. It says that certain HIV data collected and maintained by the state health department, including reports of HIV cases made by physicians, that information, once the health department has it in its possession, can only be used and disclosed for the purposes for which it was obtained, which is for disease surveillance and intervention purposes. So it also so that would be the extent to which that information can be used, the purpose for which it was obtained. The law in Maryland also specifically prohibits the data from being admissible as evidence in any legal proceeding. That's important to note that both of those things are there because there are, just a protection against, admissibility. It might not necessarily protect the data from being used for other purposes that, that are not related to it being admitted into evidence, but that we still don't want it to be used that way, like for investigations or something. So state laws can be amended to limit or prohibit disclosure for non-public health purposes. For example, prosecutions under HIV criminalization statutes are not a public health purpose. And health departments can and do participate in that process to the extent that they can under their state laws to inform legal and policy reform by centering evidence-based public health practice in advocacy efforts to change harmful laws. This again, state law sets parameters for the degree of direct involvement that health departments can have in the legislative process. But whether it's advocates directly or whether it's advocates or the health department itself directly working with decision makers or advocates with the support of health departments, health department can provide evidence to make the public health arguments for legal change. Next slide, please. But of course, a lot of states are either more permissive than Maryland when it comes to how data can be used or disclosed, or don't provide much guidance in the law at all. So each health department really has to look at what are the laws and policies in their state related to public health activities like surveillance and determine how they can comply with those laws while accomplishing their public health goals and preventing misuse of public health data to criminalize and marginalize people with HIV. Next slide, please. So how can health departments protect HIV surveillance data? Another way is through health department policies and practices. The Maryland law that I shared earlier is pretty specific, but that is not the norm. In most states, health departments have a lot of discretion on how to respond to external requests for personally identifiable information. Many of you here probably live in states where statutory changes are unlikely in the foreseeable future due to political climate, right? So health department discretion can be really important here. It's a little more dynamic than statutory language. And especially, where the law is vague, this discretion is really important. So NASTAD, we encourage health departments to work closely with their public health legal counsel to ensure protective interpretation of data privacy laws, especially when they're broad or vague. A big part of that is deepening relationships between health departments and legal counsel, between community health departments and legal counsel, making sure all parties involved understand the laws, understand the harmful implications of the laws. Don't assume that the health department lawyers understand how HIV surveillance works or anything about the technology that's related to it. They often do not, and kind of need to be educated. Typically, a health department legal counsel is often more of a generalist within the public health space, but isn't necessarily going to be focused on infectious disease or HIV. And of course, developing strong internal policies within health departments with the most protective possible approach that's allowed by law is something that we champion and support jurisdictions with doing. So since a lot of laws are broad, there's a lot of room for health department discretion, and we want to support them in using that discretion in the most protective way possible. And health departments also engage communities in dialogue about HIV data privacy to inform all of these activities, discussing community concerns, learning from community about what their concerns are, and providing information on safeguards that are already in place. Here is a screenshot of a tool that NASTAD has developed that summarizes legal protections that limit or prohibit disclosure of public health HIV data for law enforcement purposes. I'll drop a link for it in the chat right now. And it will be updated for 2024 within the coming weeks. Next slide, please. And finally, prosecutorial and law enforcement practices are a really important tool. Health departments can and do engage criminal justice stakeholders in changing HIV criminalization and data privacy laws. For example, informing prosecutorial discretion that's grounded in current medical knowledge. I have an example here from New Jersey where the Office of the Attorney General issued guidance to state prosecutors on how to approach charging people under the state's HIV criminalization statute. The guidance acknowledges that HIV criminalization exacerbates stigma and that enforcement of these kinds of laws undermine public health. And in my opinion, this guidance reflects a position that such charges are rarely, if ever, appropriate. And prosecutors considering charges under this statute must consult with the state's, basically their Department of Justice. So there's also an additional layer of review when charges are being considered. Our host today, the Center for HIV Law and Policy, has also done amazing work forging partnerships between public health officials and prosecutors to collaborate on ways to reduce prosecution of HIV. And I've added an example here in New York City, where the City Health Department has worked closely with law enforcement to expand supportive community-based services for sex workers. And drop a couple links for this reading as well. Next slide, please. I think the next slide might be my last one. So how does all of this relate to HIV surveillance data? I know this is kind of the hot issue on everyone's minds, and this is where the biggest question mark is for the community. So I want to make sure to address this. So first, remember that HIV surveillance is not a new activity. However, it's risen to public consciousness more in recent years because as the data and technology are getting more sophisticated, there are new concerns about potential for data misuse, and especially misuse for the purposes of criminalizing or marginalizing people with HIV. We don't currently have basic reason to believe that surveillance data is being sought or disclosed from health departments for criminal proceedings, but we still want to make sure that our data protections are as strong as possible because that could change at any time and the information could become more useful to prosecutors in the future. So I wanted to talk about kind of some limiting, some factors that limit the disclosure and relevance of surveillance data in criminal legal matters. Statutory protections, the ideal, of course, is for every state to have a law that just prohibits disclosure for non-public health purposes, full stop. Unfortunately, most state laws addressing health department data disclosure are broad and open to interpretation. Very few include much or any details about surveillance, HIV surveillance, outbreak response, mainly because I think a lot of these laws were written before these tools were even available, or if they were available before they were built out, really, or we were able to understand their full potential. I think lack of knowledge among legislators is also probably a factor here. Again, generalists. Even so, despite all of that, we are still reading these laws with HIV surveillance data in mind. Just because it's not specifically mentioned doesn't mean that that law could not arguably or even very clearly be read to include those activities. So it didn't have to exist at the time when the law was written for it to still, didn't have to even be within contemplation of the legislators for it to kind of end up coming within the scope of that law now. And since public health interventions and data technologies continue to expand and evolve over time, there's potential future risks that we can't even anticipate right now. Kind of like the way the people who wrote this round of laws 20 years ago couldn't anticipate, the questions that we're asking now. So this is why NASTAD has focused for several years now on proactive legal assessment. What are current limitations or gaps in data privacy protections, and how can they be strengthened with or without statutory changes? Of course, changing statutes could be a long and arduous process. There are strategic considerations depending on your jurisdiction about when and how to move for that kind of change. So again, we at NASTAD also emphasize, the importance of health department discretion and support our members in structuring internal data release policies in the most protective way possible. And finally, as of right now, there are evidentiary and procedural barriers to using public health department surveillance data in prosecutions. So health departments are therefore not necessarily the best places for prosecutors to look for evidence. And I think they know that, which might explain why, again, we don't have any reason to think that these requests are really happening, and certainly not, I have no knowledge of a health department actually releasing information in response to such a request. But again, that can also change over time. As the data evolves, the evidentiary and procedural barriers, even as they are, we all know that prosecutions can happen based on scant evidence or manipulated science. So I'm not dismissing any of those fears. And I believe that the health departments, that jurisdictions across the country should be shoring up data protections to make it impossible for that information to ever be misused in court, which again is why we focus on proactive legal assessment. And that's also why we look at HIV criminal laws alongside our data privacy research. I want to interrogate, what data a prosecutor would request from a health department in the first place. Why would they want it, and what could they even prove with it? All right, so I think that I'll now hand it over to Kay to segue into the next section on, what happens when your information does make its way to court.
Yeah, thank you guys. The cool thing about organizing these webinars, I got to learn crap about HIPAA. So basically, so like I said in the beginning, my name's Kay and I work for the Center for HIV Law and Policy. But actually for my work on this webinar, I kind of drew a little bit more from my background as a public defender, kind of talking about how I saw things play out in court, arguments that either I made or saw were made. It also means that a lot of stuff that I'm going to be talking about, I'm using Pennsylvania as an example because I'm based out of Philly. Just like how Dori was talking about the fact that state protections and laws are different state by state. It's the same thing, unfortunately, for rules of evidence. So when I say demystifying the legal process, I think it could probably be better put. I'm trying to make it make a little bit more sense, but really do welcome any questions afterwards because it's a dense mess. It's a dense mess. Can't even say it right of stuff. Dori and Rachel talked a lot about kind of what data is available, how people can get your data, things like that. And I'm going to talk about it in relation to the criminal legal system because, as many of you are aware, or if you weren't aware previously, you are now, that HIV is criminalized across the country, not in every state, but there's not HIV-specific criminalization laws in every state, but it's why this might pop up in the court. So if they have it, but something important to keep in mind is even if they have it, it doesn't mean that they can use it. So first of all, how do these mysterious government entities, also known as the police or district attorneys, how do they get your information? So there's a couple of different varieties of ways that they can get your information. And even each of these things listed here have kind of subcategories. And the one I'm going to specifically highlight is a subpoena. So one way is the warrant. A warrant is basically a detective swears or affirms that they have a reason to need to get this information, and they have a reasonable belief that their ability to search and get this information will show criminality, and then they get a magistrate or some sort of official, depending upon what the body in that area uses, potentially a non-lawyer. In Philly, it might just be someone who has some relatives in the Democratic Party, and then they get a warrant and can go after your information. And then there are subpoenas. Subpoenas, those are documents where someone is essentially being ordered to provide certain information or being ordered to come to court to testify. Depending upon the type of the subpoena, they are subject to no review. When I was a public defender, I literally had a stack of subpoenas, and if I wanted to try to get certain information, I would fill out the subpoena and serve it in the appropriate way. If the entity or person didn't want to give me that information, they could then file to what's called quash or fight against the subpoena so they didn't have to turn it over. There's also things such as grand jury subpoenas where a prosecutor has to go in front of a grand jury and make arguments that they need to be able to subpoena this information to support their case. Anyone who's gone to law school would recognize the phrase that a prosecutor can get a grand jury to indict a ham sandwich, meaning that it's a closed door proceeding that people don't know a lot about. And therefore, it is a level of protection, not necessarily that much. One of the things that's important to say that there are multiple types of subpoenas is that network of laws that Dori mentioned. A lot of them read, you have to subpoena the information. Well, what does that mean? Does that mean that a prosecutor has to go in front of a grand jury? Or does that mean that a prosecutor needs to fill out one of their subpoenas in their stacks of paper to get that information? So even though these words convey protections, there is a lot of, unfortunately, a lot of inaccuracy and gray area in them. And that a court order, which you could say is probably the highest level of protection, because the only way to get a court order, with limited exceptions that I'm not going to go into, but the main way to get a court order is after what's called an adversarial proceeding, which is an open proceeding, which if it's your information that they're trying to get, you should be present for with your attorney. And the other people on the other side are making arguments, and then a judge decides whether or not this information needs to be turned over. So it's an open adversarial proceeding. Can you go to the next slide, please? All right, so what can be used in court? Again, they let's say they subpoenaed your medical records and they have your medical records. Does that mean that all 465 pages from your hospital visit come in? No. First of all, they need to show that there's a reason to put it in. That's what the word relevant means. They need to show that providing this information will help the judge or the jury come to a decision about the case, about something was more or less likely to happen. I was just rewatching Veronica Mars, and there was a case. Then on Veronica Mars, there was a situation where they were trying to determine whether or not a witness was testifying to the truth. And that witness had testified that somebody jumped over a fence. And it came out that the person who allegedly jumped over the fence had had some sort of surgery and would have been physically incapable of jumping over that fence. That's a case where that person's medical records would have been relevant because they would have shown the judge or the jury whether or not they should believe that the witness saw that person present. And also that it's more probative than prejudicial. Just because it might provide some information on the case, again, doesn't mean it comes in. It can't come in just to make, if its impact is going to be more that it makes someone look bad versus actually explain things. An example that probably most people are familiar with are various rape shield laws where someone's sexual history and cannot be brought into court because it would be deemed to be more in that it would be less probative than prejudicial in helping the court make a decision on that case. If you can go to the next slide, please. So generally, when is your SIRA status might be relevant? It'd be relevant in a case, an HIV criminalization case, because whether or not you are living with HIV is an element or a thing that the other side has to prove to show that you are guilty of the crime with which you've been charged. It can also be potentially used. It could be used if you are the victim of a crime. For example, to show that if has like a motive for why somebody might have done the thing that they did. It can also be used potentially to show mitigation or provide reasons for the court to be lenient. Ironically, sometimes how bad things are can be used as a tool. What I mean by that is I know from talking to a friend at the Defenders, I haven't been there for a while at this point, but during COVID, she was able to get a lot of people living with HIV out on bail because COVID was running rampant in the prisons, and it was seen as a public health emergency, and getting them out from that petri dish of awfulness was used as a way of convincing the court to let them out in situations where a judge might have hesitated otherwise to let them out. So it can actually be used to for a person's benefit in cases that have absolutely nothing to do with their HIV status. Can you go to the next slide, please? And I'm just looking down, I'm checking my time, so apologies for glancing down every now and then. So will your serostatus be discussed in open court? Have you ever talked to a lawyer? And I think I unfortunately had to just respond this to one of Shakina's questions. It depends. It's the lawyer answer. It basically meaning that it is unfortunately not a situation that you can get a 100% yes or a 100% no. That said, your lawyer can fight for you as if you direct them to. What I mean by that is, let's say that you are being charged with a crime in which your HIV status is going to be, the judge has decided it's relevant, it's coming in. Your lawyer can ask for your medical records to be reviewed in camera, basically meaning that the judge or the jury takes them into the back and looks at them in the back. For these conversations to happen at sidebar, so not in open court over the mics, or for the courtroom to even be cleared. I've, in different situations than this, asked for the courtroom to be cleared when sensitive information was going to be discussed, so that way the general public at least was not in the room. So so even if it is coming in, your medical records, your medical information is going to be discussed, there are ways to still keep it as private as possible. Can we go to the next slide, please? All right. And does my entire medical record come in? So again, they got your medical records. It doesn't all come in. So there's only certain portions of it that are what are called admissible. And there's lots of really complicated rules regarding hearsay. My co-panelist asked me to talk about hearsay without saying hearsay. So I'm saying hearsay for my own amusement, but the slide I didn't include it on. So because the rules regarding hearsay, I remember studying them in law school for my criminal procedure exam. They're complicated as hell. So this is my attempt to simplify it. So basically the only thing that can come in from your medical records in Pennsylvania are your symptoms, the date of treatment, and the treatment that was provided. The rest of it, and if it is not relevant, your lawyer can ask to be redacted or blacked out, which means that even if the other side got your whole medical record, they may only be able to get in a line or two of it. I used to show up to court and I have my motion in limine, meaning a motion that I would make before, just in front of the judge before the trial started or anything like that. And I'd have various versions of redacted copies of medical records, depending upon what part of my argument won. So I would have it all ready to go, depending upon what happened. I also killed a lot of trees. And then statements for the purpose of medical diagnosis. This is the important one because anything you tell your doctor about your medical history, it comes in because it is viewed as trustworthy, because it is assumed that people won't lie to their doctors because they want to get accurate medical care. So whereas statements basically made by anyone else that appear in your medical records are very unlikely to ever come in. I say unlikely because there's situations where that can be bypassed. But if you told your doctor that XYZ, like a reason why you are seeking medical care, that kind of thing would be able to come in. The other important question that we get a lot is on the next slide, which is, can my blank testify that I told them I have HIV, i.e., in a case where you are potentially being criminalized on the basis of your HIV status, and they need to show not only what your serious status is, but also whether or not you were aware that you were living with HIV. So this is outside of the medical records, but it is medical information. So I included it as, can your neighbor, friend, sister, anyone be called to testify against you to say whether or not you were aware that you were living with HIV. And in a situation like this, potentially yes, because it's considered what's called a statement against interest, which means that it is allowed in because it's given a certain believability, or what's called credibility in court, because it is something that you said that is against your interest, meaning that why would you lie? Because you're saying something against your interest. If you're going to lie, you'd say nice things about yourself. Again, I should have put up air quotes with nice. We're talking about based upon talking about your status, which is obviously not subject to things like that. So I am sorry if I misspoke. So, but in terms of whether or not the person who is testifying as to this, whether or not they should be believed, that's not necessarily true. So the judge and the jury can still make credibility decisions and decide whether or not they're actually accurately portraying what you did tell them. So I hope that this kind of lifts a little bit of the veil up. And I'm at 15 minutes, so I'm going to pass the mic. Rachel, I think you're up.
Yep, sorry, I had trouble finding the unmute button. All right, so the last piece of the puzzle that we wanted to share with you all today is really opportunities, current and forward-looking, to be thinking about how to strengthen HIPAA privacy protections and how to shore up some of the vulnerabilities that we've talked about in this webinar, and that I am guessing you are all very familiar with in your own work. Next slide, please. So, especially, but not only, in the wake of Dobbs, which is the Supreme Court abortion case that you're probably familiar with, there's attention to this link between healthcare and criminalization in the reproductive health space. And many of us on this call have probably seen one or more of the headlines or headlines like this up on the screen that really draw attention to the risk of criminalization for self-managed abortions or miscarriages, or the risk of criminalization when we're thinking about substance use during pregnancy. Honing in on the increasing risks related to reproductive health information, in particular abortion, right? So in a landscape where we have more travel from abortion restrictive states to shield states or other states in which there's more ready access to healthcare, the administration issued this proposed rule to really be thinking about how do we prevent information from flowing back into that abortion restrictive state. And so we have this rationale that came out with this proposed rule released last year, back in April, that's really about, well, the rationale is really this idea that there's this negative impact on patient trust, on the patient-provider relationship. We really discourage people from seeking important healthcare if they can't trust that that information is private and will be used against them in harmful ways. The changes in this proposed rule really focused in on restrictions around sharing information for law enforcement purposes where reproductive health care was delivered like legally. So that's this idea again of, for example, someone seeks an abortion in a state where it's legal and returns home to a state that's more restrictive, that information couldn't flow back. That kind of restriction is supported by new attestation requirements. So this requirement that covered entities or the people requesting information attest to the fact that they're not asking for the information for a prohibited purpose, and patient notice rules. So making sure patients understand what are the protections and what are the limits of those protections on information. So we are expecting perhaps a final rule to be coming down this March. We'll see. There's actually going to be a kind of rapid response webinar for advocates that's being put on by CHLPI, leading a conversation with Kytara at CHLP, and also the Network for Public Health Law and Pregnancy Justice. And part of the reason we're bringing together those kinds of different perspectives on the conversation is because while reproductive health privacy is an area where there's a lot of vulnerability right now, we know it's not the only area where there's that vulnerability. And we know it's not the only area where there's this concern that the patient-provider relationship is negatively impacted by certain disclosures, and that discourages people or stops people from accessing really important critical healthcare services. So in our comment letter, for example, we talked about, what about HIV-related information? What about gender-affirming care? An area that's increasingly vulnerable. And also around substance use treatment, sort of lifting up folks like Pregnancy Justice, who really for a long time have done a lot of amazing work shedding light into the risks of kind of criminalization for pregnant women in the substance use space. And so again, the final rule is coming down soon, and hopefully there's good things to say from it. Stay tuned for more information. With that, I think we're actually coming to the end of our discussion. I'll ask my co-panelists to maybe come back on screen and we can tackle some discussion questions.
Thank you all for providing this amazing and detailed amount of information in a short amount of time, because I'm sure we could be here for hours going over the intricacies and the nuances and the very unique situations that HIPAA can cover or don't cover. With that being said, we do have a couple questions in the Q&A that I will, and I think, Dori, I think you're answering one as we speak. All right, so if anyone has any more questions, we're going to use the remaining 10 minutes of this webinar to answer them. So please get them in the Q&A box. And I think there was a second part of a question that was asked about, let's see, cybersecurity. And I think, I think Rachel, you answered that as well. Are there any other questions folks are wanting answered before we end the webinar?
We can, if it's helpful for folks, we can like talk about some of this stuff out loud. I don't know if everyone is like really able to see all of this here. If there's some questions here that we think could be maybe of interest to everyone.
I saw there was a question, and
why is each different?
About if traditional HIV service orgs are HIPAA covered entities. So they're not provide medical services, but they provide medical case management, food program, etc.
This is a really tough question. And I think it really depends on going back to the definition of covered entity. The healthcare provider piece of the puzzle is really broad. It's not necessarily only what we think of really of as traditional healthcare, but there's this second piece of the requirement, which is this idea of conducting certain regulated transactions electronically. And that's where a lot of social service organizations, a lot of non-traditional medical providers don't end up reaching the level of a HIPAA covered entity. And it's because they're not, submitting claims to a health insurer. They're not submitting all of these more traditional healthcare transactions that HIPAA regulates. But it's definitely something that's worth kind of working through with your organization, especially as more social services and supports are closely integrated into healthcare, right? We have all sorts of new Medicaid initiatives that bring in more community-based organizations. So it's definitely worth looking at both those sides of the puzzle.
I'm not seeing any new questions. You got 7 minutes to spare. So thank y'all for hanging in there for this webinar and asking some really cool questions. I was monitoring in the Q&A.
There's another one in the Q&A. East Robinson asks, does the DOJ or any specific groups take up the anti-Black racism component to these laws? I'm also asking the question of everyone in general because Lord knows this question's making me think.
Yeah, I think like specific, I mean, I don't think the groups I'm thinking of that would take up like that would be like focusing on this issue, like DOJ is not one of the groups that comes to mind for that. So I feel like there's government entities aside, like if we're talking about like advocacy groups or like folks who are pushing for reform, I would say that like the disparate like racist impact of these laws on people is definitely like top line messaging in those efforts. But I'm not sure what this person is referring to when they ask about specific groups.
So I guess if the question is to HIPAA and the way that HIPAA is applied, I can't think of any.
Oh, yeah.
So basically, and Ace, if this is information that you know already, forgive me for kind of going through it, but just to kind of make sure everyone has a grounding. So basically, if the DOJ is going to be involved in the case, like involving racism, it's under the Civil Rights Act of 1964 and all of the subsequent stuff. And they would become involved in two situations. One, where a law is racist on its face, like, for example, redlining laws when properties, that's actually the Fair Housing, but related to the Civil Rights Act, but where there were laws like what were called restrictive covenants that said specifically that houses could not be sold to Black people. That's where a law is discriminatory on its face. The other thing, which is what we see a lot more of now and where it's used, because the reality is, unless you're trying to make a political point, you don't make, you try to hide the discrimination, is by looking at what's called disparate impact. So if you can show that the way in which a law is being applied is negatively impacting a certain group of people on a protected class, in this case, race, then you can show that even though the law is what's known as facially neutral, i.e. it doesn't mention race, that there is a discriminatory impact and therefore it is a discriminatory law. That would be used, for example, housing. This is one of the other things I did in my past is housing, so I'm going to pull from my past history, is if you're looking at certain things like try to think of like well, I mean, they just had they just looked at some of the discrimination in Pennsylvania in education, where they found that the ways in which education is funded in Pennsylvania is discrimination on the basis of race, because essentially schools being funded based upon your geography is a proxy for race, meaning that, depending upon your zip code, you can make certain assumptions about the race that someone is, and therefore schools were getting different funding on the basis of race, and they were just using zip codes and localities as a proxy. So that said, in terms of HIPAA, they would have to show that like only certain people's records are being accessed or gotten in a certain way. They would need to show that there's some sort of discriminatory way that the law is being used. I can't think of an example of that off the top of my head. So that was my very long-winded explanation of that question.
And yeah, 1 minute to spare. Again, thank y'all for joining us today on this Thursday. And I hope this is the first of many conversations that folks have at their organizations or amongst themselves and their groups about health data privacy and its relation to criminalization. So thank you.
Thanks, everyone.
Thanks everyone for coming.